some of the infections that we normally see do make a headline, and you can see from here tracing the filly killer. So that was basically a while ago where summer of 1976, so there was a meeting taking place. And then again, people attending that convention in Philadelphia in 1976, all of them get sick at the same time. All of them, I mean, I shouldn't say all of them, but some of them, severe pneumonia. And then they would isolate a bacteria which was not isolated before. So it was discovered, so to speak, 1976. And since it was a conference for American Legion, they call it Legionella. So that's where the words come from. And again, there's always a good reason for them not to discover that particular bacteria, because there are tons of bacteria. There are like trillions of bacteria. We cannot possibly type each one of them. But once they cause problem, and then we can go. That's what we call bacterial detective. So Legionella pneumophila. Again, Legionella because of the American Legion Conference. Pneumophila means, pneumo means cells of the respiratory tract. Phila means attraction. So they have a attraction for pneumophila, pneumocytes. And of course, they will cause a pneumonia-like symptoms. Case studies, again, are important. And then sometimes the way the cases are formed, you will see that a 73-year-old man, again, he has a breathing difficulty, so it's more in senior citizens. And then again, they may have some history of cigarette smoking, 2 packs of cigarette a day for more than 50 years, of course, and then 6-pack of beer daily. I don't know what does that mean, though, but this basically caused the problem, okay? So you can see a scenario, you are in a clinic, ER, and you see a old citizen coming up, which is alcoholic, cigarette smoker, and then you look at the white blood count. That's the most important thing. Whenever you see, that's what we call complete blood, CBC, complete blood count, or complete blood profile, because that happens to be a standard for any person who has come with infection. So I want you to pay attention is that the white blood cell count is 14,000, right? Then again, if I tell you the count, you have to know what is normal cell count, okay? And then 80% of them are neutrophils. So what does it suggest to you? If I was to ask you that if you do a peripheral blood profile and you see most neutrophils. So infection, of course, what kind of infection? Bacterial, viral? You're not sure. Bacterial. It is bacterial because you need neutrophils to phagocytose bacteria. What should have been the case if had it been a viral infection? Lymphocytes. You need T cells. So lymphocyte count will go up. So a typical differentiation based upon blood is that if you have more lymphocytes, so your body is fighting with, because remember, viruses need antigen presentation. So you have to have CD4 T cells. So they have to be broken up. You have to be presented. So your body needs more of these cells to fight viruses. So you will see typically lymphocytosis. And again, they looked at the sputum. There was no blood over there. And they found out the infection with pneumophila. This is how it looks like. And then again, you can see sometimes these people have, these bacteria have like that kind of a noose. Just throw at the cell and cling onto that. That's what you see, especially over there, clinging on for some of the bacteria. There are 4 genera. Interestingly, I don't want you to know all. I just want you to know Legionella. Forget the other 3. Because it itself has more than 53 species and subspecies. So each of the bacteria, we don't go and trace them, detect them, and look after them unless they cause problem. So this caused problems, so we went after that, and we found out, and especially for those bacteria that are implicated in human disease. Right now, what we normally see is that 90% of all infections are coming from one strain, and that's Legionella pneumophila. And again, you can serotype. Most of the time, if you do serotype, that's what you normally do, 1 and 6 are commonly, this is how they do the serotypes. So you can see different type of Legionella pneumophila, and you have this serotype, and you want to make sure that they are pretty much causing human disease, and you will see from there. Okay. Again, as I announced last time, that ASM members have been helping me out in redoing these slides, and they have added some YouTube videos for those of you who are interested. And especially for this section, I think Elnas was the one who was working on that. So if you have any question, you can ask her. Okay. Look at physio and structure. Again, they are gram-negative rods. And look at the size. Remember, we're looking about 20 micrometer long. So they are humongous. And neutrophils are like 15 micrometers. So we have a challenge, such a big, so we want to go for monocytes and macrophages. And then the other problem, especially for this particular bacteria, and a very common question asked is that if you look at the clinical specimen, it's very difficult to stain this bacteria. So you have to have a special stain, deterl silver stain. So deterl silver stain is a very specific stain. So if I ask you a question in terms of combination of one bacteria with this particular silver stain, you make sure that you understand this Legionella, and very common question asked. This is a gram staining, and you can see pleomorphic forms suggesting that they could be cocci and bacilli or both. We tend to divide them into cocci and bacilli for our own classification, but probably bacteria themselves don't want to be divided in that, so they can change the form. We are interested in the growth because we need to grow them on a plate. So we need to find out how and where do they go. And as a rule, if I tell you that, you know what is fastidious? What does fastidious mean? It's an English word. Fastidious means difficult to please. If you want to please somebody and you say he or she is fastidious, very difficult to please. So that basically is a nutritional requirement for this bacteria. It's very difficult to grow. Is it good or bad for us? Well, bad and good and bad both. Because if the thing is that if it's very difficult to please the bacteria to grow, it's not going to grow easily. So that works good for us. Bad in a sense that we need to find out what does this bacteria need to grow if I was to grow them on an agar plate and want to do culture sensitivity for that. So that's going to be the problem. But you can see that we have to add supplement material there, and then we have to add different growth requirements. You don't need to remember, but just remember that the most important thing that is there for this particular bacteria is L-cysteine and iron. So once this is dividing in you, you will run short of these two, L-cysteine and iron. And then again, if you look at pathogenesis, so if for some reason you take this ability of acquiring iron from these particular bacteria, you can just soothe them down. You can just mutate them. So they need iron to grow. So if you don't give them an iron, they will lose their virulence capability. Okay? They are non-fermentative, and they get their energy from metabolism amino acid, but not carbohydrates. Very important aspect for this bacteria. So I already said to you that, especially for the American Legion Conference in 1976, Legionnaire's disease, a pneumonia kind of a thing. And it takes a while because bacteria has to, just think, let's try to relate things. If it's fastidious, if it has a complex nutritional requirement, it will build some time in you to reach a critical mass and cause problems. And you can see incubation period is 2 to 10 days. So it will take some time, and when it kicks in, then it will affect pretty much every organ in the body. It's a multi-organ disease. The other thing that it normally causes clinically is called Pontiac fever, which is again a febrile influenza-like. Many times The term influenza is a loose term and very commonly misused for public as well. Influenza basically means that you go through that phase, something is coming up, aura. I'm getting sick. That kind of a feeling that you come, especially when you have a sore throat and you know that I'm going to get flu, I'm going to get this. That kind of a feeling is where your immune system is fighting off a particular microorganism. So you kind of down in that time. So that's what happens, especially a febrile influenza-like illness. And of course, it's not fatal, doesn't cause death. And then you can see there is no clinical evidence of pneumonia. And most of the time, you see the symptoms stay for 12 hours, they stay for some time, and they disappear. So that, again, is an important differential diagnosis. When you see a patient coming up with one symptom, you want to make sure that you pretty much look at the whole picture. Again, biology as a whole, we already discussed earlier. I told you about nutritionally fastidious. And then again, the other important thing I may have mentioned earlier as well, that though it is nutritionally fastidious and requires L-cysteine and iron salt, it has this capability, a very unique capability, to grow in alveolar macrophages and even in amoeba in nature. And how does it fool our system? What does it that it cause? It prevents phagolysosome fusion. Very few bacteria would do that. So that's like an evading mechanism. Okay, we already discussed about pathogenesis. If you remember the table that you have in the first half of the test, the mechanisms of bacterial pathogenesis, some of these bacteria which are intracellular parasite. So Legionella is one of them, and it can stay in alveolar macrophages and then stay in alveolar epithelial cells. And again, remember, the advantage that they will have is that they will find an escape. So T cells won't see them, antibodies won't see them, they're just hiding there. Okay, the other important thing is that for many a bacteria, especially this particular bacteria has a pathogenic mechanism whereby it attaches to CR3 complement receptors. So that's where you saw in the previous picture I showed to you. So there was a cell, and it has like kind of a thread, a noose. You just throw over there to the bacteria. So that particular thread-like, rope-like noose is a CR3 complement receptor. So it's going to go and hook onto that particular bacteria and bring it in and have this endocytosis. And if you have a bacteria that is not combining with lysosome, again, lysosomes are the one that contain killing material like superoxide, hydrogen peroxide, and hydroxyl radical and other reactive oxygen species and reactive nitrogen species. So bacteria will escape killing mechanism because they have this capability of, and that's a virulence mechanism for them. Inflammatory response, again, is a characteristic for intracellular parasites. And then again, what you need to do is that most of the time we do need a very patent cell-mediated immunity, because once your cells take this bacteria in, they have to break it apart and present it in MSC context to T cell. So helper T cells are important. And then again, you have to activate macrophages, which have just taken in this bacteria. And if you remember cytokines, one of the most important cytokines that we use clinically is gamma interferon. And gamma interferon is important cytokine to eliminate this bacteria. And the question usually asked is, what does gamma interferon do as a treatment module for this particular Legionella infection? And the answer for that is because it kind of activates the macrophages. So macrophages get activated, and when they get activated, they have increased expression of MSC class 1 and 2. And then again, they will call in help from T cells, and T cell will pretty much take care of them. Epidemiology, they are always there at a given time, epidemic, but cases that you saw can come up, sporadic cases, also nosocomial infection in hospitals. The most important thing that you need to remember for this particular Legionella is that it is there in the water system of, it tends to be there in the water system, AC system of the hospitals. So because it wants to stay in the cooling towers, condensers, and so on and so forth. So hospital people have to make sure that they properly take care of that. And you can see 10,000 to 20,000 cases per year is a significant number. And then again, especially for those people who have a compromised pulmonary function, like they are chronic asthmatic, chronic smokers, alcoholics, they are chronic diseases like chronic renal disease, and then again, especially for transplant patient, because their immune system will be compromised, and sometimes we give them steroids, so that's an immunodepressant. Now, you can see from here, if you were to draw a chart for this particular bacteria, so you can see that they are not a problem at hot water radiators and even a hot water that we normally have in our homes. They start growing when temperature goes down. So you can see from 20 C all the way to 0 degrees C is where Legionella not only grows, but becomes active as well. So we have evaporative coolers, cooling coils, and tap water that this Legionella tends to grow. How do we diagnose that? Again, microscopy, antigen testing. We have to grow them on a culture. And also remember seroconversions. Sometimes what happens is that if you get an infection and we look for the particular antibody and that antibody is not there, and after a while we find out that the antibody is there. So there's a lag time when your body picks up this antigen and processes an antibody. So you were seronegative, and over time you become seropositive. But in this case, you can see it may take more than 6 months. So you have to wait for the test for this person to become seropositive after 6 months. And then again, we can also do nucleic acid amplification tests as a genetic test that we normally do. So these are some of the tests that we do. You can either detect the whole organism by culture, and for fluorescent activated tests, or you can look at the soluble antigen by ELISA, or you can also look for antibodies. So you can see, depending upon what specimen you have, you can either have a sputum, you can have a urine, you can have a serum, whichever way you want to go. There is a particular diagnostic test. And also remember, when something happens to senior citizens, we do have a department there in almost every hospital to take care of our senior citizens, and quite a few tests are available. How do we treat them? There are macrolides, and they happen to be the treatment of choice. And at the same time, since they are nosocomial infection, we want to make sure that they are not in the environment, especially in hospitals or in bodies of water. You want to use chlorine, or you want to make sure that you have a proper air conditioning system, so take care of that. Key points are there for you to look at them, and again, as I've been kind of advocating for the past quite a few lectures, that those of you who have bought the book with online resources, there are good flashcards, there are good case studies, and there are other learning materials for you to benefit from them. And the way they normally do is it's very difficult to kind of copy and paste or photograph or whatever. It's even tough for the instructors to pull out some data from there. So they have really worked it hard, but those of you who have paid, they should take advantage for that. So key points you can see from here that they are waterborne bacilli, and they are responsible for pneumonia, which is called Legionnaire's disease. And then the other important thing, most of the time the question will come, what are which of the following diseases are caused by Legionella pneumophila? So we'll put Legionell's disease or pneumonia, and then put Pontiac fever. And then again, there are quite a few other serogroups that we can discover, but again, most of the time, as you see in the previous slide, I said 1 and 6, but probably 1 has a more incidence as compared to 6. And especially in senior citizens, we take their sputum and test for that particular organism, or we take their urine. So that antigen is excreted in urine. And as I said earlier, newer macrolides can be given. You can give erythromycin with or without rifampicin, typical for treatment. And as a matter of fact, erythromycin, Zithromax, you must have seen, stat doses 3 days is taken as one of the commonest things for most of the infection, especially of this nature. And then for the public health department and hospital department, we want to make sure that the air conditioning systems are taken care of, and the water supplies for the public buildings are also being taken care of, and then that will present the nosocomial infection that may have. And these questions you can read on your own. And lastly, I just want to finish with this last bacteria. It's just going to take 10 minutes. Bordetella pertussis, whooping cough. So that again presents a typical age group where they have intractable cough, and it comes with severe pneumonia. And then again, remember I said earlier, most of the time that you will get a viral infection lymphocytosis, but there are always exceptions. So these exceptions become one of the good distractors for us making a good question. So you can see in this case, there is a predominance of lymphocytes. It is a bacteria, but you see lymphocytes there as an important, especially pertussis. These are very small gram-negative coccobacilli. They do not ferment, but they can oxidize amino acid as a source of energy. They are strict aerobes. So when something is strict aerobe, what does it suggest to you? If I ask you, it's a strict aerobe, what does, sorry? Of course, that will say, but the important implication is that it's going to cause respiratory infection, because where the oxygen will be is respiratory tract. So again, pertussis. And then again, it does have quite a few virulence factor. It comes in 3 stages, catarrhal, paroxysmal, and convalescent. And then again, most of us been vaccinated for that. So you have a DPT, diphtheria, pertussis, and tetanus toxoid. Pathogenesis, again, typically, as I said, attachment to the epithelial cell, proliferate. They have this particular liking for epithelial cells. So they have this tropism, that's the term I normally use. Again, they want to bind to CR3. We already discussed that earlier. This interaction between CR3 and these bacteria initiates phagocytosis. So that's a funny thing. It initiates phagocytosis, but again, it does not initiate oxidative burst. So that again is the intracellular survival, and then again, phagosome-lysosome fusion would not work. The other important thing, and it's going to be one of the questions I can tell you right away, a classical A and B toxin. I did discuss A and B toxin, some of the other things as well. And pertussin is also a classical A and B toxin. So you have a special fimbriae that again is there to attach. And then again, you have a pertussin toxin, especially S1 portion, and that basically is going to go for the regulation of adenylate cyclase activity. That's pretty much the same. So if you read that, you will see that most of the time, the A and B toxins, they basically lead to an increased cyclic AMP level. And that again, it causes subsequent increase in respiratory secretion and mucus production. Remember, in case of cholera, when I discussed cholera, I said it's going to increase the secretions into the lumen. So you lose electrolytes and water. In this case, you have more respiratory secretions and you have more mucus production. And that happens in the state we call paroxysmal state. So if you look at pathology over here, this is a ciliated epithelial cells. So it has those glycolipids attached over there. And then we have the bacteria. You can see xylem is a singular for cilia. And then they are heme agglutinin. Does anybody remember what did I say about heme agglutinin earlier? Yes, no. I said H1N1 virus, which is H stands for heme agglutinin and N stands for neuraminidase. So these are also present in viruses. And again, by the same token, you have this filamentous heme agglutinin, and then we have pertactin and many others. So once it comes close contact with that, you release pertussis toxin. It's going to increase the cyclic AMP levels. We are the reservoir for that. A very important risk factor for younger than 1 year age, especially if you are non-vaccinated and people are going to spread it by aerosol. So you're going to breathe into somebody, contaminate the air, especially for the children. And recently what has happened, I don't know whether you saw the news, that they are thinking that the incidence of pertussis is coming up. So you can see from here, that's a big challenge that we have these. So that's why the whole vaccination has to be renewed and reviewed. Because for some reason, we did fight this particular bacteria 1975 and 77, but you know, then bacteria is fighting back. So bacteria is fighting back. It has come with some of the virulence factor. And you can see 24,000 cases by the year 2005. So that's again, you may see pertussis toxins again. If you look at the clinical stage, I want you to pay attention to the duration, symptoms, and culture. You will see that you will only be able to detect this particular bacteria in catarrhal stage. So that's a typical growth curve that we saw. And in catarrhal stage, we have rhinorrhea, running nose. We have malaise, we have fever, sneezing, anorexia, and then again, paroxysmal stage, and then finally, a cough goes out. Has anybody of you ever seen a person having whooping cough or pertussis? Have you ever seen? Okay, I would want you to Google it. It's usually, if you see the baby, it's very, very pitiful. It's like this. That voice comes. That's called whoop. There's a cough with a whoop. That's a typical voice. So if you go, it really kind of, tires the patient, and they have to go, like your tantrum. See that tantrum that the babies go through? So that kind of typical thing that comes with a whoop, that's where the word is coming from. If you look at microscope, you'll see this bacteria, culture, nucleic acid amplification, but the most important thing is detection of IgG and IgA, and that's probably is a confirmatory test that we normally ask you and want you to know. Treatment, again, macrolides, typically upper respiratory tract, erythromycin, and then again, we can use that for prophylaxis. We have to use vaccine, and as we discussed earlier, pediatric vaccine where you have these booster doses, DPT 1, 2, 3, so on and so forth, and you can see these vaccinations are there important. And as I said earlier, we are now seeing adult cases of pertussis whooping cough as well. And again, age distribution, you will see over here that we have infection reported in 19 red bar and as compared to the blue one. So you will see that recently, again, the question I'm going to ask you from this slide is that you see recently increasing trend of incidence of pertussis infection in patient more than 25. That's what it is. So in 1988, if you look at the red bar, the incidence was declining with the age. But with the blue bar, which is 2005, the incidence is increasing by the age, so that's important. Okay? And then again, some of the questions, these are from your online studies book. that you can prepare yourself and see what is it that we need to know. Okay?